So 17 OHP, the major role is to identify CH. Anybody with non-palpable gonad, do it after 72 hours. Levels are more than 100. It's 21 hydroxylase deficiency. DHEAS, the role mainly is combined biosynthetic defect. Low levels in this setting suggest a star SCC and high levels suggest 3-beta HSD in a XY individual with DSD. Androstenedione predominantly for 17 beta HSD defects. If your andro is high, testo is low, think of a 17 beta HSD problem. Testosterone for Leydig cell function, and of course less than 100 means decreased production. More than 100 nanogram per DL will suggest that there is a resistance. DHT, the major role is 5-alpha reductase versus androgen insensitivity syndrome. And again, you do it after 7 days or HCG stimulated. Levels more than 10 for testosterone to DHT ratio is 5-alpha reductase. When you are doing this testo DHT ratio, what is the thing you need to be cautious about? In terms of very practical issue. So what are the usual units of testosterone which are there? Or nanogram per ml, the multiple ones. And for DHT, they come in picogram. So you have to convert them to the same unit. And often if you don't do it, your results will be quite confusing in that perspective. AMH is more for Sertoli cell function, XY more than 30, XX less than 10. HCG test as discussed, if LH is less than 0.7, give HCG 5000 international unit per meter square or 1500 units. 0 and 72 hours, you do the basic test, testo, DHT and andro. Now, just to summarize, if we talk about XX DSD, the main thing to look at is 17 OHP, DHEAS and DOC. If 17 OHP is very high, more than 100 or more than 30 also, think of 21 hydroxylase. If everything is high, especially DHEAS is very high, think of a 3-beta HSD. If you have a very high DOC, think of a 11 hydroxylase deficiency. Remember, newborns may actually have mild salt wasting in 11 hydroxylase because their level of aldosterone is not high enough to match that in that perspective. If you have a high 17 OHP and DHEAS, POR defect may be also likely. Now, impaired DHT effect, we've discussed a lot. What about the biochemical parameters? So you will look at basically DHC7, you will have syndactyly and salt wasting, your cholesterol will be low. Star side chain cleavage, you will have salt wasting with low metabolites. 3-beta HSD will have high pregnenolone level. 17 hydroxylase deficiency will have hypertension with high DOC and 18 DOC. And 17 beta HSD3 will have a complete reversal, which will happen. POR, you will have salt wasting. 5-alpha versus complete AIS, we already discussed that testo to DHT ratio is a guide as to which way you're looking at, and whether somebody is feminizing or virilizing during puberty will tell you whether it's a AIS versus a 5-alpha reductase deficiency from that perspective. What about genetic testing? Now, genetic testing is becoming more and more available, and studies have shown that if you do a targeted panel or a clinical exome sequencing, you will be able to identify many cases in that regard. So generally, the role of genetic testing is increasing. For XX testicular DSD, which is a XX male, look at SRY and NR5A1. XY DSD, androgen receptor, NR5A1, WT1, SRY, and all the genes. And for dysgenesis, WT1 becomes important. So now we have a panel testing or a whole exome sequencing, which will give you the correct diagnosis in that regards. Once you diagnosed a child with atypical genitalia, look at association. So XY DSD, go for abdominal imaging to look for any tumors, look for proteinuria for Fraser syndrome, look for renal dysfunction. XXY individual, they behave like Turner syndrome. So Turner associations like cardiac, renal, hearing, all those things become important. Look for aortic diameter. Y cell line especially is very, very important when there is a doubt, especially for a gonadal malignancy. So if you have a palpable gonad, the first thing to look at in a child with DSD is whether palpable gonad is there or not. If there is no palpable gonad, look for Mullerian structures. If the Mullerian structure is present, this is basically XX DSD. Look for 17 OHP and DOC, which will diagnose CH. If these levels are normal, aromatase is a second possibility to think of. Maybe go for a genetic testing in that scenario. And then if there are other features, think of dysgenesis. So this is the easy arm of XX-DSD. Mainly 17-OHP will give you the diagnosis in 90% of cases. If you have palpable gonad present and you also have a Mullerian structure, it basically means that AMH is either not there, that means there is a dysgenesis or a AMH deficiency, or it's not acting, their AMH is high. This will be the rarest scenario in which you have got both palpable gonads and Mullerian structure, and AMH level will give you the clue. Now, if you have no Mullerian structure, irrespective of whether you're talking about palpable gonads being there or not, you are dealing mostly with a XY DSD. So look at testosterone. If testosterone is low, salt status is abnormal, you are dealing with a salt wasting form like CAH, 3-beta-HSD, or hypertension, 17-hydroxylase deficiency. If this is normal, LHCG receptor, 17-beta-HSD. On the other hand, if testosterone is high and DHT is low, it's 5-alpha reductase, and if it's high, it is AIS. So this is the general sort of a overview in terms of 2x2 table of palpable gonad and Mullerian structure will give you a clue. You have got no palpable gonad, Mullerian structure present, XX-DSD, get a 17-OHP done. If you have got both palpable gonad and Mullerian structure, get AMH done to differentiate between AMH deficiency and resistance. If you do not have a Mullerian structure, get a testosterone done to look at low levels less than 100 or high levels more than 100. In high levels, you do a DHT level to classify 5-alpha reductase versus AIS. If testo is low, look at salt status to identify combined adrenotesticular defect like 3-beta-HSD, side chain cleavage, star, 17-hydroxylase in another form, or isolated defects like LHCG receptor or 17-beta-HSD from that perspective. So Dr. Seema is asking poor resources, what minimum investigations we can do. So as discussed, Dr. Seema, essentially the most important one will depend upon the sort of a scenario you're dealing with. XX-DSD, 17-OHP, electrolytes, XY-DSD, testosterone, electrolytes, that will give you a clue. If you have got both Mullerian testicular structures, go for AMH. This will be the one. Skeletal changes are seen in FOX9 and SOX9, and the other gene is POR in that regards. Dr. Bharani is asking, in a baby with DSD, uterus detected in ultrasound, can inhibin A give a clue about over-testicular disorder versus persistent Mullerian duct syndrome? Inhibin A is a difficult test. It actually needs to be done in a stimulated form. So it's usually been done in an experimental process. But yes, if inhibin B is present, it means that there is a over-testicular disorder. So if you go beyond the normal workup and you are getting confused, this would be a test to look at in a particular scenario once you find that in that setting. So I think it's a test which is not routinely indicated, but yes, in certain scenarios can be of help.